Buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Y antes de dar inicio a nuestras sesiones, recordamos mantener en silencio sus micrófonos. Ahí mismo les recordamos que las preguntas las podrán realizar a través del chat. Las formularemos a nuestro ponente al final de sus presentaciones. Y les pedimos que nos hagan favor de llenar una encuesta de satisfacción y esa liga la podrán localizar en el chat o bien a través del código QR. En nombre de la Escuela de Medicina y Ciencias de la Salud, les doy la más cordial bienvenida a la sesión académica de Pediatría. En esta ocasión tenemos extraordinarios ponentes con un tema igual de relevante para el pediatra. El trastorno de déficit de atención e hiperactividad, diagnóstico y tratamiento. Esta plática va a ser impartida por el doctor Juan Francisco Lozano y el doctor Daniel Coury de Nationwide Children's Hospital en Columbus, Ohio. Me voy a permitir dar una pequeña reseña de nuestros ponentes. El doctor Juan Francisco Lozano estudió medicina en la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey. Es un honor tener a uno de estos exalumnos en esta sesión. El doctor Lozano realizó una maestría en investigación clínica y administración regulatoria en Northwestern University, Evanston, Illinois. La especialidad de pediatría la realizó en Children's Hospital of Michigan en Detroit y actualmente se encuentra realizando una subespecialidad en desarrollo y comportamiento en Nationwide Children's Hospital, Columbus, Ohio, en uno de los centros pediátricos de mayor prestigio en Estados Unidos. El doctor Juan Francisco Lozano está certificado en pediatría, en investigación clínica y en la atención de discapacidades del neurodesarrollo. El doctor Daniel Coury estudió medicina en la Universidad de Tennessee en Knoxville. La especialidad la hizo en Le Bonheur Children's Hospital en Memphis. La especialidad en desarrollo y comportamiento en Rhode Island Hospital Providence en Rhode Island. El doctor Coury es profesor del Departamento Clínico de Pediatría de The Ohio State University College of Medicine. Es director clínico para la salud del desarrollo, director del Departamento de Pediatría del Desarrollo y Comportamiento, director de la Clínica de Comportamiento y Discapacidades del Aprendizaje, director del Programa de Entrenamiento en Comportamiento y Desarrollo. Todos estos cargos los ejerce en Children's Hospital, Columbus, Ohio. El doctor Coury recibió una distinción en el 2015, distinción que da Nationwide Children's Hospital, que es el Golden Stethoscope Award. Es autor de múltiples publicaciones y bueno, nos da mucho gusto que estén aquí con nosotros. On behalf of School of Medicine and Health Science of Tecnológico Monterrey, you're most welcome, Dr. Lozano, Dr. Coury, to our grand rounds. We're very pleased and very happy to have you with us. Looking forward to listen to you, so let's start it.
Great. Thanks very much, Dr. Valencia.
Muchas gracias. Entonces, en lo que empieza a presentar el doctor, vamos a hablar sobre, como decía, el tratamiento y el manejo y el diagnóstico del trastorno por déficit de atención e hiperactividad en nuestros pacientes. Next, please. En sí no hay algún conflicto de interés. Please. Y el objetivo del día de hoy es poder identificar cuando llegan nuestros pacientes a consulta con algún problema del comportamiento, cuáles podrían ser un trastorno por déficit de atención y entender cuál es el manejo clínico de este diagnóstico, tanto con terapias conductuales como el manejo médico, tratamiento. All right, next, please. Es el diagnóstico del trastorno por déficit de atención. Existen varias guías clínicas y las dos van de acuerdo. Y esta es la Académica Americana de Pediatría y la Académica Americana de Psiquiatría Infantil y del Adolescente, basando sus criterios diagnósticos en el Manual Diagnóstico y Estadístico en su edición número 5. Y lo que involucra esto es la utilización de la entrevista clínica, tanto al paciente, al cuidador, entonces papá, mamá, algún otro cuidador, y utilización también de cuestionarios que vamos a ver más adelante, tanto para el padre como para los maestros, para cuantificar y ver cuáles son estos síntomas o signos que están presentando. Y luego enfatizar mucho del cuál es el impedimento, qué tanto está impactando clínicamente en su vida diaria. Next, please. Entonces, la Académica Americana de Pediatría hizo su actualización de las guías clínicas y parte de eso es que cada vez que se presenta algún niño con un probable caso de un trastorno por déficit de atención o TDAH, se recomienda iniciar una evaluación, sea en cualquier niño de 4 años en adelante, utilizando los criterios diagnósticos de DSM-5 y evaluando en más de un área de impedimento. Entonces, casa, escuela, alguna otra actividad y utilizando información de varios cuidadores. Next, please. El pediatra, entonces el clínico, tiene que estar informado o estar evaluando las comorbilidades que podemos ver. Y aunque no vamos a estar ahorita abordando las diferentes comorbilidades, es importante conocer que pueden tener ansiedad, depresión, trastorno desafiante, problemas del aprendizaje, que en algunos casos pueden venir con el TDAH o estar como un diagnóstico diferencial. Importante reconocer también que el TDAH es una condición crónica y por tal, como hemos hablado en otras presentaciones, ese modelo de manejo crónico del medical home o de la casa dentro del su pediatra es el abordaje que tenemos que dar a estas familias para tener un seguimiento muy cercano. Next, please. Entonces, la evaluación, como decíamos, es importante incluir tanto a los padres que nos van a dar mucha de esa información como al niño. Obviamente, dependiendo de la edad, qué tanta información nos puede dar, pero ellos muchas veces nos pueden decir información muy relevante. Y evaluando cuáles son sus problemas de atención, concentración, tanto de hiperactividad, qué tanto batallan para quedarse sentados, qué tanto interrumpen a otros y qué tanto han estado presentes estos signos y síntomas. Para poder así llegar a un diagnóstico y ver en qué ámbito está presente, porque queremos, al ser TDAH un trastorno del neurodesarrollo, estamos esperando que sea algo que realmente estamos viendo durante todo el día y por lo tanto lo vamos a ver tanto en casa como en escuela y otras actividades. Next, please. Los criterios diagnósticos estamos viendo tanto la inattención como la hiperactividad. Y aunque hay 9 síntomas, los niños al menos deben de presentar 6 para poder decir que tienen los síntomas, los criterios diagnósticos, en este caso para inattención. Y la falta de atención se puede manifestar en diferentes entornos, ya sea académicos, ocupacionales, sociales. Y puede ser que no presten atención a los detalles, cometen muchos errores, tienen dificultades para mantener la atención con actividades, incluso actividades del juego, completar las tareas, parecen distraídos o en algunas ocasiones incapaces o es difícil para ellos escuchar con atención o escuchar instrucciones, dificultades por organizar sus tareas y actividades de la vida diaria. Por esa dificultad, algunas veces es difícil para ellos llevar a cabo todas estas actividades y llega a ser una actividad que a ellos no les gusta, es desagradable para ellos por la atención que requiere. En algunos casos, los estímulos que para nosotros tal vez serían irrelevantes, no pondríamos atención a ellos, suelen ser difícil de ignorar y puede ser una distracción muy frecuente para ellos. Llegan a ser olvidadizos en sus actividades de la vida diaria, desorganizados, pierden materiales, los tienen dispersos, digamos que tienen mugrero en su escritorio o en su cuarto. Y en los entornos sociales, a veces como se puede notar esto, es la falta de atención para, por ejemplo, cambiar en conversaciones, están cambiando muy frecuentemente, difícil seguir instrucciones, reglas del juego. Next, please. En cuanto a la hiperactividad, esto, pues igualmente necesitamos tener más hiperactividad e impulsividad, más de 6 síntomas de los 9 descritos aquí. Y la hiperactividad también se puede manifestar como inquietud, están en frecuente movimiento, no pueden permanecer sentados, están corriendo, trepando en diferentes lugares que en ocasiones es inapropiado, tienen dificultad para pues, jugar o participar en actividades tranquilamente, o siempre están hablando en su juego o en sus actividades, interrumpiendo a otros. Y este nivel de actividad va variando con la edad y el nivel de desarrollo, y por eso es importante hacerlo con precaución cuando estamos hablando de niños más pequeños. Los niños hiperactivos también tienen dificultad para permanecer sentados, y tratamos de ver lo que sea en general en todas las áreas o actividades que están involucrados. Entonces, no nada más que sea un tema de interés. Y la impulsividad, pues lo vemos como alguien que está diciendo las respuestas sin pensar, no tiene dificultad para esperar su turno, o está interrumpiendo frecuentemente o hablando durante la clase. All right, next. Entonces, los criterios diagnósticos, como decíamos, tenemos los síntomas presentes de inatención, hiperactividad, impulsividad. Y lo importante es que estén interfiriendo, que estos síntomas estén presentes antes de los 12 años de edad. Entonces, lo podemos ver históricamente, que estuvieron presentes desde más chicos, pero cómo están afectando en su vida diaria. Puede ser que más tarde es cuando nos presenten digamos, los síntomas o las preocupaciones dentro de la escuela o sus actividades. Como decíamos, como es un trastorno del desarrollo, queremos ver que esté presente en más de 2 ambientes. Entonces, escuela, trabajo, actividades en la casa, y tener evidencia clara que estos síntomas que están presentando afecten su funcionalidad en los diferentes aspectos de su vida y la calidad de vida. Y bueno, que no estén explicados por algún otro trastorno psiquiátrico o algún otro desorden que pudiera ser TDAH. All right, next. Y bueno, entonces hay diferentes subtipos, como decíamos, hay criterios diagnósticos para cada uno. La inatención, pues va a presentar los criterios diagnósticos solo para inatención y no los cumple para hiperactividad. De la misma manera para hiperactividad e impulsividad. Y está el combinado, en el que presenta los signos y síntomas y los criterios diagnósticos para ambos. Entonces, así es como los definimos. Y bueno, vamos a seguir. Next, please. All right, Dr. Coury.
Thank you very much. So as Dr. Lozano pointed out, the criteria, one of the things to always remember is that the last D in ADHD is disorder. So if you have a disorder, you should have clear signs of impairment, not simply symptoms. As we went through the various diagnostic criteria for ADHD, you saw a number of symptoms that many of you might think, well, I have that, but you probably don't have enough of those symptoms on a daily basis that it is causing you impairment. People with ADHD have many of those symptoms on a daily basis everywhere they go, and it's causing impairment. So part of our goal in evaluating a person for ADHD is to determine if there is functional impairment in their home or in their school or occupational settings. We also want to use some rating scales to corroborate this diagnosis. It's not enough just to get a history from 1 or 2 people, but in fact, it's very helpful if we get information by rating scales, because we can monitor this as we track our treatment and response to treatment. We also want to do a physical examination to rule out any medical problems that might be causing this. For example, hyperthyroidism can cause problems with overactivity and poor sleep and difficulty sitting still. So we want to examine the patient, check their vital signs, see if there are any other medical conditions that might be causing any problems, any medications that they might be taking that might be contributing to these symptoms. And then, as Dr. Lozano pointed out, what we have learned is that our best outcomes will come when we identify and treat any co-occurring conditions, such as anxiety or depression or oppositional behavior. So these are the components of our evaluation of ADHD. When we talk about rating scales, a commonly used rating scale is the Vanderbilt rating scale. It's a very straightforward scale that lists the 18 criteria for ADHD that Dr. Lozano described on the previous slide. Each of those criterion is scored on a 4-point Likert scale, ranging from 0, where the symptom occurs never or rarely, all the way up to a score of 3, where a symptom happens very often. So with 18 criteria, a maximum score of 3 for each of those, on the Vanderbilt rating scale, you can achieve a maximum score of 54. And most typically developing children are going to score in the range of about 20. They'll have some of these symptoms sometimes, some of them never or rarely. Most children with ADHD will have scores that'll be in the range of the 30s to 40s. When we score the Vanderbilt, items that receive a score of 2 because they occur often, or 3 because it is very often, those are the symptoms that meet ADHD criteria. So when we mention that we need to have at least 6 out of 9 of the criteria for inattentiveness, it's item marked as a score of 2 or 3. And then that total score for all 18 items, we track that, because as we treat them, you will see that score improve. In addition to the ADHD criteria, the Vanderbilt scales also list the criteria for the most common co-occurring conditions, and those are oppositional defiant disorder, anxiety, depression, and conduct disorder. In addition, learning disabilities often occur in children with ADHD, so there are questions about the impact of the child's symptoms on their academic performance. And all of this can be monitored longitudinally as response to treatment for each child. Now, previously, we went through some of the action statements from the American Academy of Pediatrics guidelines from 2011. The 5th action statement gets into our treatment for ADHD. And treatment recommendations vary according to the age of the child. For young children, preschoolers in the 4 to 5-year-old age group, our first recommendation is for evidence-based, parent or teacher-based behavior therapy. Many of these children will not require medication if they can get good behavioral treatments. If the behavioral treatments are not providing adequate improvement, medication may be used, but it's considered optional. We try to avoid using medication unnecessarily on the young children. For school-age children, age 6 to 11, our first choice is to move ahead and use an approved medication and an evidence-based parent or teacher-based behavior therapy. Again, behavior therapy has the possibility for lasting change. It doesn't require medication to be in the body for that patient to have a change in their behavior. So behavior therapy, if it is available, is considered one of our best and first treatments. But for school-age children, we often use medication along with behavior therapy. For older children, as we get into the teenage years, the 12 to 18-year-olds, if the child is not being identified until this age, then the recommendation is to immediately start with medication, assuming that the adolescent agrees with this treatment. And we may prescribe behavior therapy as well, but it is difficult to get adolescents to agree to this and to participate with this. If you can, it's wonderful, but it is difficult, as you probably know from dealing with adolescents for a variety of other health conditions. The final action statement was for the primary care pediatrician to adjust the medication to receive maximum benefit with minimum adverse effects. So there is no ideal dose for any child. It's the dose that works best for them, given the benefits of the medicine and the adverse effects that the child may be experiencing. When I talk about behavior therapy, there is a parent-based behavior therapy program known as the Incredible Years program. This program has been duplicated internationally in many countries, and it teaches parents the principles of behavior management, including setting limits and providing reinforcers for good behavior. It's a manualized program. So while the guidance that I may give a family in my clinic visits is all appropriate, the benefit of a manualized program is that we don't miss any steps, and it can be carried out by non-physicians who have been trained to deliver the program. The goal is to prevent and treat young children's behavior problems and promote social and emotional and academic competence. It's evidence-based, a tremendous amount of evidence supporting its effectiveness. It has been translated into Spanish, and you can find more about it at this website link to theincredibleyears.com. Beyond behavioral therapies, and behavioral therapies here in the United States and in many countries are difficult to obtain. There are not enough providers, and according to different healthcare systems, the availability of this for families may not be there. So we often turn to medication for treating ADHD. Our first choice medications for treating ADHD are what are called the stimulant medications. Here are a list of several of the stimulants here that are approved in the United States. The methylphenidate products, which go by names such as Ritalin or Concerta. There is a single isomer dextromethylphenidate product known as Focalin, which also comes in an extended release version. And then the amphetamine class of stimulants, dextroamphetamine, mixed amphetamine salts, and the pro-stimulant lisdexamphetamine. There are also non-stimulant medications that are used for ADHD, and these include atomoxetine, guanfacine, and clonidine. Some of the medications that are available in Mexico, again, the methylphenidates that I mentioned, Ritalin and Ritalin LA, or long-acting. Concerta is another long-acting version of methylphenidate. And Tradea LP is another long release medication. In the amphetamine group, Vyvanse is available. And with non-stimulants, atomoxetine and clonidine are available under the trade names of Strattera and Catapressin. So let's consider a typical sort of case that you might see in your daily practice. Joe is a 7-year-old boy whose mother describes problems with inattention, hyperactivity, and impulsive behavior, and these are occurring both at home and at school. He is in the 2nd grade, and he is struggling in school. He has trouble sitting still, and he often disrupts the classroom. His family is concerned that these issues are interfering with his school performance. So we have many symptoms here that suggest that Joe may have a problem with ADHD. So our assessment process, as we've mentioned, is we want to assess for the presence of those DSM-5 criteria. If we follow those criteria carefully, we will not overdiagnose a child based on just 1 or 2 symptoms. So we want to assess that presence. We want to find evidence that there is impairment. If Joe is still making excellent grades and has excellent friendships with his peers, he may not have ADHD. He may have a problem with behavior management. And then finally, we want to use those behavior rating scales so that we can further confirm any other conditions that might be present. Now, when we use all of this, we put that together with the clinician's judgment. So those rating scales do not make the diagnosis. Like any other lab test, they help confirm your clinical judgment. So we use those to track progress in our treatment and confirm our clinical judgment, but the clinician makes that diagnosis. So in this case, we've got Vanderbilt rating scales completed by the parent and the teacher. Remember, we want to get information from another adult who knows the child. If the child only has these problems in one setting, such as with the parent at home, or only with this year's teacher, there's a problem with that setting and perhaps not a problem with the child. So we want to get the perspective of more than one adult who knows the child well. And in Joe's case, the parent and the teacher are in agreement on symptoms of inattention and hyperactivity and impulsivity. The parents have a total score a little higher than the teacher's score, but both of these are elevated scores for ADHD, strongly supporting a diagnosis of ADHD. The oppositional defiant disorder screen does not show much symptoms, neither does the conduct disorder screen, but the parents are reporting some symptoms of anxiety or depression. The teacher does not see this in the classroom. And the parents are seeing more areas of impairment than the teacher sees. And when we look at how impaired Joe is, both the parents and the teacher come up with similar scores. So they are pretty much in agreement here as to Joe's symptoms and how difficult they are. As Dr. Lozano mentioned, one of our first steps is to identify ADHD and treat it as a chronic condition. 30 years ago, the thinking was that children outgrew this as they became young adults. We have found now that adults continue to have ADHD symptoms that affect them in the workplace. So this is a chronic condition, a lifelong condition. As part of our treatment plan, we want to target our outcomes. What are we trying to get our treatment to do? We're going to use stimulant medications and behavioral therapy as indicated, and we're going to monitor that response systematically. So that's our overall plan for treatment. Now, 25 years ago, a large study was done called the Multimodal Treatment of ADHD study. We call that the MTA study. And in that study, the question was, what is the best treatment for ADHD? In that group, there were controls who did not have ADHD. One group was treated with medication only. One group was treated with behavioral therapy and no medication. A third group received both medication and behavioral therapy. And the fourth group was sent back for community care. They were identified with ADHD on enrollment in the study, and for their treatment arm, they were referred back to their primary care provider for treatment, whatever your primary care provider wants to do. The study lasted 14 months, and after 18 months, this graph shows how many of these children had normalized their behavior. In other words, their scores on the Vanderbilt rating scales and on teacher reports had moved to the normal range instead of the ADHD range as a result of the treatment they were receiving. And so you see that over half with medication were normalized. With behavior management alone, a third normalized after 18 months. So I want to emphasize, if you have access to behavioral therapy, you can prevent or avoid the need for medication with many of these young children. And the combination was even better for those who have certain problems. The community care at that time lagged behind the treatment that they were receiving in the research group. And I'm going to show you more about that on the next slide. But I really want to emphasize our treatment for ADHD can be very successful in the majority of cases when we use medication and when we use behavioral therapy along with it. So the treatment that was most effective was the intensive behavioral intervention combined with medication, and that was statistically similar to medication alone. Community providers tended to use lower doses, and 25 years ago, we did not have the long-acting medications we have today. As a result, children were taking medicine twice a day, and there was concern about taking it 3 times a day because of effects on appetite and sleep. But in the study, these children were being treated 3 times a day and were getting more medication than was clinical practice at the time. And as you saw on the previous slide, they had better outcomes with higher doses of medicine. And then where did the behavioral therapy help the most? It helped most for children with oppositional behavior. I often tell parents, I do not have a medicine that will turn no into yes. We require behavior management to get people to change their behavior. Medication for ADHD can improve attention and concentration. If the child is trying to do what is requested by the teacher or the parents, the child can be more successful. But if the child is refusing to do this, I do not have a medication that will change that refusal. So this MTA study really shaped our current practice with ADHD because we've started using higher doses than we were using 25 years ago, and we rely a lot more on extended release, once-a-day dosing because of the improvement with clients taking it and its benefit throughout the day for the patient. Our first-line medications, when we choose medications, are the stimulants. The stimulants have the highest efficacy of any medication out there. And every new medication that comes on the market in the United States compared to a stimulant medication as part of the approval process. We still haven't found anything better than the stimulants, and we've been using them for ADHD for about 85 years. The stimulant medicines, as I briefly described earlier, fall into the categories of methylphenidate products and amphetamine products. And all of our science shows that they are equivalent. Nothing to show that methylphenidate works better than amphetamine or the other way around. So we can use either category of stimulant medication. The recommendations are to start low and adjust slowly. Remember, we want to minimize the side effects and maximize the benefit. And for compliance reasons, it's often preferred that we use the long-acting once-a-day medications. The side effects of ADHD medicines include a reduced appetite. This is the most common side effect in almost 2/3 of patients. Some of them also report problems with abdominal pain or with headache, and it may cause difficulties with sleep. That's more along the line of 10% of patients. Sometimes too much medication of a stimulant can cause tics, and rarely we may see hallucinations, in which case we want to discontinue the medication immediately. That reduced appetite with methylphenidate, immediate release, and with amphetamine, it's about 30% of cases commonly will report this. With atomoxetine, a non-stimulant, about 15% report reduced appetite. And this is a concern because poor growth can result from decreased nutritional intake. We want to be certain that the patient is going to grow appropriately. Studies have shown that there are height deficits of about 1 centimeter per year. And for typically growing children, that may not be a concern. The benefit may outweigh any loss in potential height. But for very short children, it may be a very important factor. We also monitor those weight deficits and continue to try to do things to assure that the child is growing appropriately. Studies have shown that when we stop medication treatment, that children return to their previous growth rates and they compensate for that after a couple of years. But generally, higher doses increase the reported side effects. Other adverse effects of stimulant medicine includes aggression, irritability. Some children will become socially withdrawn instead of being as active and outgoing as they were before. These are stimulants, so they can cause a slight increase in blood pressure or in heart rate. That is rarely a concern in children. It's more of a concern in treating adults. And then, as we mentioned, appetite suppression and sleep disturbances and tics are also concerned. Lastly is the concern about diversion or inappropriate use of these medications. So these are controlled substances and they are monitored closely in our prescribing of them. Our second line of medications are the non-stimulant medications. They are second line because they have lower efficacy. They don't work as often as the stimulants, and when they work, they don't have as big an effect size. They do not work as well, but they are efficient. Often we will use them as an alternative to a stimulant where a family is concerned about stimulant medicine, or we may use them as an adjunct to a stimulant so that we can use a lower dose of a stimulant and reduce those side effects that we were just discussing. The first one is the Atomoxetine, which is a norepinephrine reuptake inhibitor. It is very much based on weight. We do not do a lot of adjusting of the dose there because the first dose that we start them on is pretty close to the highest dose appropriate for their weight. Because it is a reuptake inhibitor, it often takes several weeks for it to reach its full effect. With alpha agonists, much like the stimulants, we start low and we titrate. We want to minimize the side effects and maximize the benefits. These do not work immediately the way that stimulants do. They may take a few days, but they will start working more quickly than atomoxetine does. The two alpha agonists that are approved for use are guanfacine and clonidine. Clonidine is available in Mexico. As I mentioned, for atomoxetine, for younger, smaller children under 70 kilos, to start at 0.5 milligram per kilogram per day, and then increase to 1.2 milligrams after about 3 days. This reduces problems with drowsiness and with appetite. The maximum dose is 1.4 per kilogram per day, or the 100 milligram size capsule. For older children who weigh over 70 kilograms, we start at 40 and go to 80, and if necessary, move on up to 100 milligrams. Titrating the guanfacine and clonidine, we start at the lowest dose, that's the smallest size tablet, once a day, and then increase it weekly. There's no need to increase it more rapidly than that because you will probably use more than you need to use. And then we reach a maximum dose, a maximum recommended dose of 0.4 milligrams per day for the clonidine or catapressin. The adverse effects for the non-stimulants, again, atomoxetine can cause some high blood pressure or tachycardia, some GI upset, and some behavioral activation where parents may say it's making my child worse. Of great concern is suicidal ideation. This is very rare. It is about 1% of the time, but if you are seeing this, you should discontinue the medication. With the alpha agonists, these are used to treat high blood pressure, and so our main side effects are going to be hypotension or bradycardia. And they also have a tendency to cause some drowsiness or sedation, so monitor for that. Now, I mentioned how this can all affect appetite, and we have found through many studies that nutritional deficiencies can further impact on ADHD symptoms. Several micronutrients have been associated with neurodevelopmental disorders, including ADHD, and there have been trials that have suggested that some supplements may improve ADHD symptoms. So you may need to consider some supplements to help make these ADHD medicines more effective. Important nutrients to consider: iron. Iron is an important factor in the function of the central nervous system. It's also helps protect against lead exposure. And so if there is iron deficiency, you want to treat that. That can help improve the ADHD symptoms. Zinc is another nutrient that is important, and studies shown that zinc can help improve the efficacy of stimulant treatments. So consider that and optimize dietary zinc. Magnesium is another element to consider. It is associated with some distractibility and hyperactivity. And so if your patient is deficient or you are concerned about their diet, a magnesium supplement might be useful. Fatty acids have also been identified in recent years, especially with depressive disorders, and using omega-3 supplements can be very helpful with improving the mood and irritability seen in many of these children. A lot has been done looking at additives, preservatives, dyes, salicylates, and sugar. Additives such as aspartame or MSG, the nitrates that are used as preservatives in many foods, artificial food colorers, especially red number 40, yellow number 5, and yellow number 6, and then some natural salicylates that occur naturally in many fruits and vegetables. The studies looking at many of these have failed to show that they are a significant cause of ADHD, but there have been some studies that have shown that when we reduce exposure to some of these, symptoms may improve. No real reports where they have completely resolved or treated them simply with diet, but we do want to keep an eye on that. Here in the United States, some of the common food products that have some of these dyes, they can be causing this. Some people are sensitive to this. If a parent comes in and says, my child just goes crazy whenever he has this food, advise them not to give their child that food. It doesn't usually require major dietary change. Most children can do fine without M&Ms or without Skittles. So it's usually easy to remove that. Special diets, such as the elimination diets, they may be helpful, but unlikely unless they have other food-related symptoms. The Feingold diet has been around for over 40 years, and there is not enough evidence to support using this for everyone with ADHD. Studies have shown that a small percentage, 1 or 2% of children, will respond well to these diets. So if a parent says, I've noticed this, encourage them to stay away from that food. But if you put every child on one of these diets, 99 out of 100 families are going to be disappointed in your treatment. Megavitamins also have failed to show benefits. So let's go back to Joe and what we've been doing for him. We diagnosed ADHD with Joe, and we started him on Concerta at 18 milligrams each morning. 18 milligrams is the smallest size tablet of Concerta here in the United States. After a week, we see no side effects, but we don't see any benefits either. So we increased his Concerta to the next size tablet, 27 milligrams. After a month, Joe comes back to the office, but there's been communication with the family during this time. And during this time, we've increased him again to 36 milligrams, the next size up, and we've repeated those questionnaires. And what we see now is that the teacher is very pleased with how he's doing in school. His symptoms in the school, as rated by the teacher, have moved down to where his symptoms look like other children who do not have ADHD. The parents also are seeing improvement, not as much as the teacher is, but they do see improvement here. This may be because the medicine has worn off by the time he gets home from school at the end of the day. We didn't have problems with oppositional behavior or conduct behavior, and his anxiety has improved, perhaps because now he is able to sit still, do his work, complete his work, and he isn't worrying about tests and worrying about getting in trouble for his behavior in class. So some of that anxiety may have been related to his ADHD symptoms rather than a second condition. So what if Joe starts developing tics? Well, that might be too much medicine, so we may need to back off and see about adding a different medicine to help. Or we could switch him over to a non-stimulant medicine completely, such as Clonidine. What if he stops gaining weight? As we mentioned, that's a big common side effect. Well, we could reduce the dosage, or we could try switching to a different stimulant. Also want to do our best to work with the family to make sure that they are attentive to his diet and that they're providing him with extra snacks at times of the day when the medicine has worn off. And what if his symptoms still weren't adequately treated and we got to the highest level of a medicine? Well, that's when we need to switch to a different stimulant class, or we may add one of those non-stimulants such as Clonidine to see if that will help with managing his symptoms. So at this point, that's all of the prepared presentation that we have, but Dr. Lozano and I would like to open the floor to any questions people have.
All right. So, Dr. Coury, I've been receiving some questions here in the background. So I'm actually going to make them to you, and probably you can answer those. So,
Okay.
so one of the questions is, what are the out of the three types of ADHD, which is the more frequent? Is it hyperactivity? Because that's the most frequent we see in consult.
So the most frequent is what we call combined type, where they have hyperactivity and inattentiveness. That occurs in about 80 to 85% of cases. The next is the inattentive type, and that's about 15%. These are children who sit there quietly, but they are not paying attention. Their mind is elsewhere. The hyperactive only is actually the smallest group, only about 5%. These are the kids who are falling out of their seat at class, but if the teacher thinks they're not paying attention and says, Joe, what's the answer? Joe knows the answer because he's paying attention, but he can't sit still. That's very uncommon, only about 5%. The most common is the combined.
Next question is, what's your experience with the Daytrana patch? Is it worth it?
So for years in the 1990s, we talked about how we wanted a patch like the nitroglycerin patch that's used for people with cardiac problems. By the time the patch came out, we had a number of other extended release formats that made the patch less necessary. We have sprinkles that we have capsules that can be opened and sprinkled. We have chewables, we have liquids, all in long-acting formats. So the patch has not been a big part of my treatment. I do have some patients who take it because it is very steady, provides a steady release of medicine for many hours. But one of the problems is it takes 2 to 3 hours to start working. So parents have to go into their child's room and put it on them in the morning before they wake up, and then remember to take it off at the end of the day. It does work well for some children. For the very hyperactive ones, it does not work as well because it has such a slow onset of action.
Right. So here's a question, I'm just reading it. How frequent is it to observe a high IQ with inattention and anxiety in the classroom? So saying that for this reason, the child is getting bored or confused.
That's an excellent question. As I mentioned, if you have ADHD, it's a disorder, and so that should be affecting your performance. And if you have a high IQ and you have these symptoms, but you're still making excellent grades, it doesn't look like that's causing impairment. However, this are the kind of kids who are first identified sometimes when they get up to about age 12, because they're very bright and their intelligence has helped them overcome that short attention span. But as they get up into middle school and high school, the teaching and the information is coming so quickly, they can't keep up and they end up needing treatment. Now, the anxiety part of this may come because they have not experienced problems with learning or making good grades before, and so this can be quite a change to them. And that's where you see that the treatment involves medication with the adolescent's ascent. The other part that you were mentioning, though, is that with the anxiety and the children acting out because they're bored, that's where you want to get back to this. When they're making great grades and not showing impairment, but people think this child has ADHD, this is the kind of child we need to dig a little deeper. And if you ask the kids, because they are getting the work done and keeping the grades up, I am bored, I'm finishing before everybody else. And so these are the kids who need educational interventions. They need to be stimulated and given some more work that is interesting to them because they're bored. That's a great question.
Yeah, thank you. So another question is, what happens when the impairment is not actually for the kid per se, but for those around him?
So when it's impairing those around him, what we are saying is that this is keeping this child from doing age and development appropriate activities. In other words, the child's hyperactivity is such that peers and friends, classmates don't want him around. So they don't invite him to birthday parties. They don't want to play with him. So it is causing impairment, even if it isn't causing impairment with perhaps grades. But the other part of your question, if it's causing impairment for those around him and it's only the parents, not when he's in school, not when he is with his soccer team and doing what the soccer coach says and so forth, then we have to look at the parents' expectations, and they may have the wrong expectations for a child his age where other adults see what's going on. That would be the other thing to look at. So it's probably impairing something. Lastly, is sometimes we see that a parent has some mental health issues. A depressed parent finds a typically developing child overwhelming and can't deal with it, but teachers and others don't have a problem with that child. So that's, again, one of the reasons that we gather information from more than one adult who knows this child.
Question is, so which or when would you recommend neuropsychology testing to diagnose ADHD, or for the kid with ADHD when they're having academic or school problems? When would you recommend it? Before or after treatment? And if it's after treatment, how long after initiating treatment?
Another great question. 30 years ago, there was a lot of controversy. Should we get this testing done before we start medication? Nowadays, the thinking is if we have done, we've described in today's presentation, primary care pediatricians can make the diagnosis and begin treatment. Now, remember that chart we showed where Joe's teacher says he's doing much better. Children who are having problems with academics because of their ADHD, when we get their ADHD under control, their grades improve. If we get it under control and they're finishing their work, they're turning in their work, they're paying attention, and they are still struggling, that's when we start thinking perhaps there is a learning problem here. And that's when we should be getting the neuropsych testing. So if we go that route, you won't need psychological testing for most of the children with ADHD. You'll be able to manage them in your practice with the strategies we described today and without requiring referral to a psychologist.
Right. There's one final question here. So say a child has an anxiety disorder already diagnosed and under treatment, but they feel like ADHD is also present. What is kind of like the next step medication that could target anxiety and ADHD?
That's another great question. Assuming that the anxiety is under treatment with behavioral therapy, such as cognitive behavioral therapy, but now we're concerned we may have ADHD, any medication could be used. The stimulant medications have the possibility of worsening anxiety, but most patients with ADHD will still do well on a stimulant medication. Another possible choice would be atomoxetine. Atomoxetine is a norepinephrine reuptake inhibitor, but it has some overlap with the serotonin reuptake inhibitors, so it has some benefit for anxiety. Not enough that it's a first-line anxiety medication, but enough that you might want to consider trying it first in a patient who you previously have identified with anxiety, and now you're considering medicine. Now, if this patient was already on an anxiety medication, then I would simply recommend treating the ADHD as you would any other patient with ADHD, but do go slowly with the stimulant medications.
All right, that was our last question, Dr. Valencia.
Well, thank you very much, Dr. Coury, for your excellent presentation. And I would just like to ask you, what would be your last takeaway message for our audience?
My takeaway message is ADHD, the mystery about it that we had 30 years ago, most of that has been resolved. And at this point, primary care pediatricians can manage the majority of cases of ADHD. So I want to try to make you feel comfortable with doing this and assure you that you can do a good job for the majority of these children.
Dr. Lozano.
Pues muchas gracias. Igualmente ese es el objetivo de que ese diagnóstico, ese miedo al uso de medicamentos, el manejo del TDAH, que es algo muy común y que se hace frecuentemente, así es que es algo, un fácil manejo y que impacta en la calidad de vida de todos nuestros pacientes y a largo plazo.
Well, thank you very much to both of you. We're very pleased to have you with us. It was a very good presentation, so thank you very much. Have a good day y les agradecemos a toda nuestra audiencia el haber estado con nosotros. Que tengan un excelente día. Thank you.
Muchas gracias.
Thank you.